So welcome and thank you for joining us today for providing psychosocial support during pregnancy, labor, and delivery. My name is Meg Miller and I'm the Vice President of Marketing and Content Strategy for the Wellness Network. I'm honored to work with hospitals and specifically maternity departments from across the nation to deliver our award-winning health, wellness, and patient video education to support your needs to meet compliance, distance learning, and meet perinatal core measures. I met Dr. Sue Hall 6 years ago when she started advising me about the NICU market and patient education needs specific to that space. I've had the pleasure of working with her throughout these past years as she's continued her focus on research and development of resources to address psychosocial aspects of care, specifically in the NICU space for NICU and maternity staff and patients that they serve. I'm very pleased to host Dr. Hall in today's discussion, where she will share the science behind the value of employing psychosocial support and principles of trauma-informed care to improve outcomes for maternity patients and staff, and host what we hope will be a vibrant discussion with you about your experience in this area, both during COVID and what you saw pre and hopefully post-COVID. Additionally, we'll provide an overview of caring for pregnant patients and their families, provide psychosocial support during labor, delivery, and pregnancy, a 6-part program developed in response to a federal grant to improve healthcare for pregnant women by educating their providers in psychosocial support and trauma-informed care. This program has a focus on education for both providers and patients and does allow for CEU credit. So welcome, Dr. Hall, and thank you for joining us today.
Thank you, Meg, for having me, and welcome to all of our attendees. And if I could just ask you to take a moment to share your place of work and your work role, that would be great. You can do that in the chat box so that we know what kind of an audience we have. So I am a neonatologist by training, but as I'm sure you're aware, neonatology is actually called neonatal perinatal medicine. So I'm sure I've been in labor and delivery thousands of times during my career and spoken to thousands of pregnant patients in my role as a neonatologist. My partner is Kira Sorrell. She's not with us today, but she is founder and executive director of the NICU Parent Network, and she coordinates our involvement of parents and patients as collaborators in our educational development process. This is a photo of what we all hope to see at the conclusion of a successful, safe, and healthy delivery, which is a satisfied mother, a relaxed and happy father, and a baby who's happy to be outside with his mom. I want to start by explaining this educational program that we're going to be talking about and how it came to be developed. So I am with the National Perinatal Association, which is the only multidisciplinary group of professionals working in the perinatal area. It was started, I think, in the 1970s. And at that time, ACOG was forming, AAP was forming, AWAN, NAN, all of the sort of siloed professional organizations for doctors and nurses and other healthcare workers. But the National Perinatal Association saw a need to convene people across disciplines, and so it was formed. And as I mentioned, we have collaborated with the NICU Parent Network to form a little company, essentially. It's a nonprofit under the umbrella of the National Perinatal Association. And we are working to provide online continuing education programs to healthcare workers in the perinatal space. Our mission statement is to become the preeminent provider of compelling perinatal education on psychosocial support created with interprofessional collaboration. So we don't do any education on medical aspects. We are simply here to fill the gap in what we perceive is a gap in training on how to talk to patients, how to support patients, how to empower patients, and how to maintain staff well-being as well. So to accomplish this, as I said, we always have a team of parents and professionals, parents or patients, who work together through every step of our course inception, creation, implementation, and follow-up. We believe our content is very engaging. We have lots of stories that we include from the parent or patient point of view. We run a survey before we develop each course, asking parents or patients what their experience was like. And throughout our course, we highlight the good parts of their experience as well as the things they found challenging. The courses are very evidence-based. They include best practice recommendations, and they provide lots of resources and takeaways, I call them, to download. So I like to call the courses one-stop shopping. We have kind of scoured the internet for resources on the different topics in the courses and included links to other sites on the web that may be useful to you. And again, lots of downloads of examples of what you can do in your own hospital. So because I'm a neonatologist and also I was a social worker before I became a neonatologist, I've always been interested in the concept of psychosocial support. And so we started out in the domain of NICU parents. And we convened a work group of about 50 people. This was in 2014. And came up with the interdisciplinary recommendations for psychosocial support of NICU parents. We looked at the NICU landscape, and we know the same is true in the labor and delivery landscape, that you have protocols for management of all of your medical situations. Maybe you have a protocol for antepartum hemorrhage, a protocol for preeclampsia. And so in neonatology, we had protocols for lung disease, heart problems, et cetera, but we didn't really have any guidelines for how to interact with patients and parents. So we came up with these recommendations. We published a special edition of the Journal of Perinatology, which was 6 different articles on all of the topics in that educational program. As we traveled around the country talking about these recommendations, everybody would say, well, these are great recommendations, but how do we do it? How do we operationalize it? How do we bring it to the bedside? And one of our topics in our recommendations was on the topic of staff education. And if you keep up in the literature in healthcare in your field, I'm sure you will see calls over and over for staff education on this topic. So we worked for a couple of years, pulled together our initial program, which was called Caring for Babies and Their Families, and we launched that in January 2018. Since that time, we have had the complete NICU staff from 14 different hospitals go through this program, which involves over 800 learners. We've given 2,500 continuing education credits through our partner, which is called PACLAC. And we conducted and then published a study demonstrating the program's efficacy in improving nurses' knowledge and attitudes towards providing support to parents initially after taking the course, as well as at 6-month follow-up. The positive changes were maintained. So after accomplishing that, we certainly knew that our NICU families come to us through pregnancy, labor, and delivery. Many of them, as you all are well aware, have numerous social and mental health high-risk factors that antedate their pregnancy. Their pregnancies may have been high risk and their deliveries may have seemed traumatic to them. And so being cared for using principles of trauma-informed care throughout their maternity journey may make their NICU journey easier. And of course, it's not all about NICU families. They represent a small percentage of all of your patients. And we feel strongly that the same concepts should be applied to all patients who are pregnant. So we developed our maternity program, and I'm going to just mention briefly what each of the courses focuses on. The thread throughout the entire program is the use of trauma-informed care. If you're not familiar with this concept, it was developed by SAMHSA, the Substance Abuse and Mental Health Services Administration of Health and Human Services in the federal government a couple of years ago. And it has since been blended into care in all sorts of places, like in adoption, in criminal justice, in pediatric care, child abuse, things like that. The bedrock of trauma-informed care is what traumas have people experienced in their lives before this healthcare encounter that may impact how they behave and respond in this healthcare encounter, and how can we minimize that this healthcare encounter will also be traumatic or triggering for them. So we focus on trauma-informed care, give some about the physiology, why it's important, how the body responds. We have a big piece on communication with marginalized patients, including the LGBTQ community and Black and Indigenous people of color. We talk about delivering unexpected news, which is a paradigm shift from delivering bad news. And if you take the course, you can learn more about where that came from. The next big course is perinatal mood and anxiety disorders. And as I'm sure you're all aware, perinatal mood and anxiety disorders and depression specifically is the #1 complication of pregnancy. And nationally, it has received a lot of attention in terms of screening for depression. And the idea here is that frontline providers, such as nurses and physicians, need to know how to recognize these disorders so that they can refer and get patients hooked up with treatment and follow-up. Next, we have courses that go through each sort of time period of pregnancy, starting with antepartum support. And in that course, we talk primarily about patients who have high-risk conditions that may require hospitalization, or they may be followed as outpatients. We talk about preeclampsia, premature rupture of the membranes, pregnancies with fetal anomalies, and what the specific psychosocial concerns are of those patients and how they can be addressed. We also talk about supporting patients who have early pregnancy loss, whether that is in the first trimester or getting closer to the second trimester. Next, we have a course on intrapartum support, and this focuses on working with patient expectations during labor and delivery. It talks about birth plans, the pros and the cons, and how to sort of talk to patients about their birth plans. We address the topic of obstetric violence, and I'll talk about that more in a moment. If you're unfamiliar with that term, I'll explain it. And again, we talk about supporting those with fetal demise or neonatal death, so death closer to the time of delivery. In our postpartum support course, we talk about the 4th trimester and its importance. It has long been an overlooked and somewhat neglected area of maternity care. And we know that most deaths related to pregnancy do occur in the postpartum period. And we also know that follow-up for patients during the postpartum period is not as robust or complete as it should be. So some of the things that need to be addressed during the postpartum period are talking with patients who have had traumatic deliveries, helping them process and understand what that was all about to try and ward off the development of PTSD, which has been well documented to occur in women after difficult deliveries. We go over the criteria for screening for depression, what to do if there is a positive screen, supporting breastfeeding, which is all important, and encouraging patient follow-up and outreach to, again, patients who are marginalized and may be less likely to come back for their checkups. And we always include a course on staff support. Our understanding is that staff cannot have the emotional energy to support patients if they are not themselves also supported. And we know that secondary traumatic stress syndrome is a huge occupational hazard for people who work in labor and delivery. And so how can we deal with that, again, to prevent nurses and doctors from quitting the field, which actually does happen related to secondary traumatic stress syndrome. We have a piece on bullying and, again, how to deal with that in your setting. This is just to show you the qualifications of the people who have contributed to this course. And now that I look at it, I realize that some of these people were authors on our COVID course, and I have left out some authors. So we had a big group from the University of North Carolina at Chapel Hill. But the point is that we always have psychologists, we always have obstetricians, we always have neonatologists, we always have parents, patients/parents who contribute to our courses, and most of them have academic credentials. Let me move this out of the way. So why do your patients need your staff to take this program? As I mentioned earlier, depression and perinatal mood and anxiety disorders are the #1 complication of childbearing. And as many as 50% of those mothers with symptoms will not seek treatment. So that increases the responsibility of primary providers to be able to recognize these disorders. And that's what we want to do through our courses, is to give you the skills to not only recognize those disorders, but try to prevent them, try to minimize them, try to mitigate them, and arrange follow-up when it is appropriate. Wanted to talk for just a section about the intersection of trauma and childbirth. So again, going back to trauma-informed care, many women will come into maternity care already having had a history of physical or sexual childhood abuse, 1 out of 3. And sometimes we encounter patients and we label them difficult patients because they won't cooperate with an exam, or they are just challenging to manage from an interactional perspective. And part of that might be due to the responses they're bringing to this encounter because of their history of previous abuse. And 1 out of 3 women will be sexually assaulted in her lifetime, and women of color are particularly at risk. 1/3 of women will perceive their birth experience as traumatic, even though for us, the caregivers, what any one patient may consider traumatic to us might be just another day taking care of patients. We don't see it as traumatic because it was over quickly, it had a good outcome or whatever. But what our goal is to attend to the emotional state of our patients, not just our own interpretation of what they should think about their delivery. Studies have documented that pregnant women who have histories of abuse or trauma experience greater pain and distress, have higher rates of medical complications, and exhibit decreased communication with healthcare providers than others. So again, having some understanding that something in this person's background may be informing their behavior is what this is all about. You don't have to know exactly what trauma any specific person has experienced. You just have to accept that patients are using coping mechanisms they developed at some point in their life. They may not be appropriate in the current situation, but that's all they have to draw on. And one of the reasons we're so concerned, myself as a neonatologist, about postpartum depression is the effect on the child. So when mothers have either postpartum depression or anxiety or post-traumatic stress disorder, their interaction with their infant can be altered. They become less engaging, they can become overly restrictive, things like that. And these actually do lead to worse outcomes in terms of their socio-emotional health, their intellectual development, developmental outcomes, and their health outcomes. And 1 in 7 mothers will develop a perinatal mood and anxiety disorder. So the question is, do you know enough about PMADs to make a difference? We talk about caring for LGBTQ patients, and most lesbian women seeking maternity care report experiencing some type of discrimination. One of these 4 types, either exclusion from care, assumptions of heterosexuality, inappropriate questioning, and sometimes even refusal of services. So in our course on communication, we talk about gender neutral language, we talk about how to engage and welcome all types of patients to your practice. Racism is currently a topic of huge concern across the country, and as well it should be. Black women compared with white women in the United States have a 2 times higher rate of complications, higher rates of traumatic birth, 3 times higher chance of death related to pregnancy causes, 3 times higher chance of adverse birth outcomes, including low birth weight and premature infants, and worse health outcomes even when income and education levels are similar to whites. And so I'm sure you're all familiar with the case of Serena Williams, the tennis player, and her experience on a maternity ward, and how she felt that her concerns were not listened to with equal concern because she was a Black woman, and it resulted in her having delayed diagnosis of a pulmonary embolism. This type of experience is reported over and over in literature. There's also a body of literature that describes how chronic stress that people who experience racism, how it affects them, and it contributes to wear and tear on their bodies and what is called weathering of their biological systems. So weathering means essentially that their body is almost aging faster than it should. And one of the statistics in pregnant women that supports this is that for white women, they're going to have their best pregnancy outcomes in their 20s. But for Black women, already in their 20s, they're experiencing health concerns, a higher incidence of preeclampsia and things like that. And so their health outcomes for their infants are actually best in their late teens, which is a difference from white people. So I mentioned that I was going to introduce the topic of obstetric violence. This is a term, I'm not sure it was generated by the World Health Organization, but these are the 5 categories of obstetric violence as defined by the World Health Organization. So when they decided to tackle this problem, it is a problem worldwide, perhaps even more than it is in the United States, but certainly we see some of the things on this list happening in front of us almost every day. The first thing is routine and unnecessary interventions and medicalization, either on the mother or the baby. Verbal abuse during care or labor, delivery, humiliation, physical aggression, things like yelling inappropriately at the mom that she's not pushing hard enough, that if she would just try harder, the baby would be born, holding her legs together until a doctor arrives, preventing her from delivering, all kinds of things like that. Lack of material and inadequate facilities. This would represent a situation where women are delivering in the hallways of really busy hospitals and things like that. The next one is practices performed by residents and professionals without the woman's permission, which would have been obtained after providing her comprehensive, truthful, and sufficient information. Some examples of that are performing vaginal exams when the woman is under anesthesia for a procedure, when all of the doctors line up to feel what the abnormality is before the surgery actually takes place, and they haven't discussed this with the woman. And of course, any type of discrimination on cultural, economic, religious, or ethnic grounds can be considered a type of violence. And some people object to the word violence. It is very strong, but it is useful to think about situations in which the care that we give is inappropriate. I mentioned early on that working in maternity care was a high-risk occupation. 75% of OBGYN healthcare workers, so that's both physicians and nurses and midwives, will experience emotional distress related to their work. Think of the extreme shoulder dystocias. Think of the stillbirths. Think of the extreme hemorrhage experiences. Think of the extremely preterm delivery. Those are all distressing situations that we encounter. And nurses actually have the highest burnout rates of any profession, and so nurses in particular need support. Development of PTSD, or what's called secondary traumatic stress syndrome, is a potential occupational hazard, as I mentioned. So secondary traumatic stress syndrome is like a person is getting PTSD by witnessing someone else go through a stressful situation. So why should you be interested in this program for your staff? Well, some of the reasons are maybe you have low patient satisfaction scores. Your staff might not feel like they have the tools to address all of these kinds of difficult situations with patients, and that may lead their interactions to be less than desirable from the patient's point of view. If you're a supervising nurse, you might see your staff struggling when interacting with patients and families. You might sometimes feel they don't understand the patient perspective. Sometimes care practices are arranged around what's convenient for the medical and nursing team. If you have a lot of new graduates who are just gaining their sea legs, so to speak, they might benefit from the help this program offers. If you have bullying in your unit and you want to have everyone take a look and try to help solve that problem. If your staff morale is low, it might be low because people just don't feel like they have the skills to deal with both the medical problems and the psychosocial problems of your patients. Is everyone in your unit on a different page? And finally, are you hoping to transform your unit's culture into a more patient and family-oriented culture? This program was created for any type of maternity care provider, not only obstetricians, family practice physicians, maternal fetal medicine specialists, nurses, inpatient, outpatient, antepartum, interpartum, postpartum, midwives, social workers, lactation consultants, nurse educators, and doulas. So as Meg mentioned in the beginning, and as I outlined, this program offers 6 courses. The primary courses, the really important courses that provide an overview, are the communication course and the perinatal mood and anxiety disorders course. And I think too that the staff support course is very important. Aside from that, it depends on how you staff your area in which you work, whether nurses rotate between labor and delivery and postpartum or whatever. You might consider selecting different courses for different staff, like just your labor and delivery staff take the intrapartum. But really, all of the courses are helpful for any healthcare worker in perinatal care, because you get an understanding of the whole spectrum and how things go over time and the different things that come up in each stage of pregnancy. When we introduced our program into the NICU space, we had some of our units make it a required part of their staff education program. We know that most hospitals do provide a certain number of hours per year for their staff to engage in continuing education. And at least in the hospital where I worked, of course, many of the staff would go to conferences to fulfill those requirements. So now that going to conferences is made greatly more difficult and they're all online, this is an option for your staff to get education online. Also, in the NICU, we made some of the courses a part of a quality improvement initiative. In other words, you can do an assessment of your labor and delivery unit or wherever you work, identify what issues you want to improve, and then use the course as a way to get into how to improve those issues. We do have the option that hospital departments can sign up as a group, as we've done with the NICU, or people can sign up individually. We think that this program provides value to hospitals because the education is focused on improving communication. And if you hear anything from JCAHO and the other organizations that oversee the care that we give, it's communication, communication, communication. Communication is at the root of many of the problems that we see in patient care and many of the dissatisfactions and even lawsuits that arise out of care. So improving communication and mental health support is a valuable thing to have. Again, we have many clinically relevant web links and downloads. We do provide continuing education credit. And it's our hope that you would have better staff retention if staff feel better equipped to handle some of these difficult situations that we've outlined and avoid burnout. These are some examples of the resources we provide. So web links and how-to downloads for you or your staff. Birth preferences for parents anticipating a loss. What that is a worksheet that can be used during an antenatal consultation to help parents prepare the environment in which they want to deliver and manage their child. Of course, we don't want a patient who's carrying a fetus with an anomaly to present to labor and delivery and nobody know how to approach them, how to help them through this difficult time. It's so much better if it's talked about in advance, if the parents feel like they have some control over the situation and making the decisions, and if everybody on the staff knows who's going to be responsible for caring for this baby. Do they want NICU care? Do they want comfort care? Is it going to be provided in labor and delivery or on postpartum? These are things that are helpful to discuss ahead of time. Another one of our handouts is called Humanizing Birth. Does the language we use matter? And the answer is yes, the language we use does matter. That handout talks about how we refer to patients as the previa in room 4 and things like that. So we really want to move as much as possible away from identifying our patients as numbers and diagnoses and things like that and talk about them as people. We have patient-facing downloads that can be distributed to your patients. One example is antepartum support resources for women with high-risk pregnancies. So if you have a high-risk antepartum unit where women are hospitalized for a period of time, we have links to a whole variety of peer support organizations that those women can connect with. There is a cost to the educational program that relates to our cost for getting continuing education credits. $10 per nurse per CEU, so $60 for the program, and the price is higher for physicians and midwives, as you can see there. I wanted to take a second to just let you know that the Wellness Network also has patient-facing resources available. And this is the link. Maybe we'll come back to it in a minute. There's a passcode where you can get in and see all of the resources that they have curated for your use. This is what the Wellness Network's patient education library looks like. And you can search for the category you are looking for. While I have the chance, I don't know if anybody was with us a week or two ago when I talked about our COVID-19 program, but we also have developed this COVID-19 program, again, in response to a federal grant. And the charge from this grant was to provide virtual training and trauma-informed care for frontline maternity providers. So the timing of this was perfect, as we had just completed our maternity program, and so we just added on a COVID program, and we have bundled it with our communication course and our perinatal mood and anxiety disorders course. Those three courses together are available to anyone for free, although not for credit. If people want credit, then we have to charge for the credits. The purpose, the reason that the Health Resources and Services Administration of the federal government put this into the CARES Act on the coronavirus pandemic was to arm frontline providers with basic skills in mental health assessment and support techniques to stave off or minimize the mental illness pandemic that many have predicted is coming, and the literature already shows some evidence of that with things like anxiety and depression and insomnia and drug use and alcoholism and things like that already on the rise. I wanted to introduce you briefly to our website. It's www.myperinatalnetwork.org. You could also type mynicunetwork.org. They come to the same place. And then from here, you can click on My Perinatal Network to see what the offerings are for maternity providers. This is further down on our homepage. Again, you can click in here to perinatal care. We have NICU care, and then we have a page for our COVID offerings. Once you sign in or click to see what the courses are for perinatal providers, you get onto our learning platform website, which is myperinatalnetwork.com. That's what this looks like. And we also, on our maternity page, have what we call a sneak peek. The link is here. I certainly don't expect you to copy that down, but if the slides are made available after this presentation, you'll see that. But the easiest thing to do is just to go to myperinatalnetwork.org, click on the maternity program, and about halfway down the page, you will see this link that says sneak peek. And when you click on that, it will ask you to put in a code, and it's case sensitive, and this is what it is, sneak peek _MC for maternity care. What the sneak peek is one page, quote unquote page, from each of our courses in the maternity program. So it gives you kind of a drive-through of all of the courses. This is what being inside the course looks like. Every course starts with an introduction and then objectives. We always have a family story, so we're very keen on the patient experience and the patient voice. The idea is to get you to understand what it's like to walk in the patient's shoes and be on the receiving end of care. This is one of the key quotes. Seems that many health professionals involved in antenatal care have not realized that one of their roles should be to protect the emotional state of pregnant women. And that's what we're trying to do with our courses. As you go through the course, you'll encounter a whole variety of topics. At the top of each page is the objective to which that content is tied. Each course ties up with a summation of what staff can do. These are specific bedside, hands-on examples of things that you can do to make the patient experience better. And then each course has a summation page with key points that we want you to take away from the course. Again, this is our website. You can email help@myperinatalnetwork.org, or you can email me personally if you have any questions about our programs. And so now I would like to open it up to questions and answers. And if you have any questions, we would certainly welcome them in the chat box. And I see that Meg has put up a poll on this.
So I did launch a poll just to get an idea of what you're currently using or if people are using anything. So please go navigate to the poll function on your webinar and complete the poll. And we would also like to hear from all of you, share a little bit about like just, you know, who you are, your title and the location where you practice, just so we have an idea of where you're coming from. One of the questions that I also wanted to sort of pose to the group was to ask if you're interested in sharing a little bit about your experiences and maybe challenges you've had in implementing programs to meet the trauma-informed care and psychosocial support. And if you have something you'd like to share, all you do is raise your hand and I can unmute you because we would like to hear your voices as well. And thank you for those who are completing the poll. I can see that it's, some people are completing it. And so while we wait for that, is there anyone on the group that would be willing to share anything, any of their own experience? Just simply press the raise your hand or chat and I'll go ahead and unmute you. We'd like to hear a little bit about what you are using or what you're trying to use or any challenges that you've seen, maybe even specific to the time that we're in right now with COVID. Anybody willing to share? While we wait and see. So it looks like people have tools to educate and screen their patients during pregnancy, which is of course important, but not many have, let's see here, Peggy, let's go in there. So you should be able to speak now, Peggy.
Okay, I have had experience working at many different places in many different roles. And at one hospital, I was a perinatal support coordinator. But I do see, really at most hospitals I work at, I'm in the Chicago area, not much support for patients at all, or very limited, in the sense for any kind of trauma, staff understanding what they need to do with patients who have a history of trauma, or even, the COVID thing, forget that. Nobody is providing support for anybody on that. I just have been very disappointed. So when you offered this webinar and I got the information about it, it's just something I've been passionate about and trying to get out there for patients, because there's so many people that are struggling with, previous trauma coming in, or even being traumatized by their delivery or by their care that they received. So.
Yeah, and so Peggy, we'll make sure that we'll be sending a follow-up email so that you got the overview from Dr. Hall. The follow-up email will actually provide the link so that you and any of your colleagues can register to attend that program that she described in there to help meet those needs, and especially if you can get buy-in from those around you so that there's a cohesive, standardized approach as well. Would be great.
Also, Meg, I believe that you're going to attach the brochures to our programs to the email that you send in follow-up. The brochures are available on our website as well, and they, again, list the courses, all of the course authors, the learning objectives, and so forth.
Yeah.
When you approach your hospital administration, if you decide to bring this forth as something you would like to see for your unit, I will just tell you the most common barrier that we come up against, which is not paying for the courses, because the courses really aren't overly expensive. The question they'll hit you with is, who's going to pay for the nurse's time to take the course? If hospitals make it required, then they pretty much have to pay the staff's time. How we face that in my own hospital is that, as I mentioned, every nurse is allocated, I don't know, let's say 5 hours or 10 hours of continuing education time that's paid. And so we started the course program at the beginning of the year when they hadn't used up their paid education time, and we just allocated it all to the program. Some hospitals have, as I said, incorporated into their staff education, which they do once a month. So we had one hospital that did one course in January, and then they all talked about it. A different course in February, then they all talked about it at their staff meeting. A different course in March, and we're able to roll those out on a month-by-month basis if that's what works for your hospital. So there are all kinds of ways of options. But if you, Peggy, if I heard you say that forget about COVID, nobody knows what to do on that, maybe a good place to start would be the free COVID program, which has the 2 key courses of communication and mood and anxiety disorders. And see how that goes. And then if you're interested in the other ones, you can pick and choose from the menu of courses that we have.
Right.
Yeah, I find,
oh, sorry, go ahead.
oh, I was going to say, I find I will look and refer things to staff, just to, sometimes staff is overwhelmed with everything else. I think there's been a lot of, at least where I work and I know around us, where they have cut back staff. And so staff is working probably even harder than they've ever worked. And that's where sometimes having the time to spend with patients, nurses don't, I mean, they may want to, but they don't necessarily have the time to sit and talk with a patient or, spend the time to understand what the patient's going through. So I think we need to kind of come up with creative ways that maybe don't cost anything, just to get people or, staff to know how important this is.
Well, part of the course just focuses on, I'm going to use the word universal precautions. How can we interact with all patients? So even though their time is more limited, it can be more focused. It can be focused on how to empower the patient, how to engage the patient in their own care, how to do collaborative decision making. So we want to get away from the model of nurse and doctor tell the patient, this is what we're going to do, to engaging the patient. So it may not necessarily take more time, it's just a little bit different approach.
Well, good. Well, thank you.
Thank you, Peggy. So you have a question from Kathy. She's asking, so there's a question in the chat, and then we're going to get to Lita. So Kathy's question is, how long is each course and how many CEUs are they worth?
Okay, that's a good question. I'm sorry I didn't mention that. Each course is worth 1 CEU, so approximately 1 hour. Some people go through them in 30 minutes, some people take longer. It depends, the time that an individual takes depends on how much they're going to explore all of the resources. Like if you clicked on every link and opened every download, it might take you longer than an hour. But they are supposed to be an hour, and they provide 1 CEU per course.
Thank you. And Lita, you just have to unmute. I have given you permission to speak, so please go ahead and ask your question.
It's not a question. I have a comment. I work at Amita Health Alexian Brothers, and I apologize. I missed the beginning of this because I was actually teaching in our perinatal intensive outpatient program. So I don't know if you mentioned our program, but we do have the only perinatal intensive outpatient program in the state. So we are often providing support for moms who are having, traumatic experiences, both while they're pregnant, history of PTSD, or, because of traumatic experiences in labor and delivery. And we, whenever we possibly can, work with them to develop birth plans, and we work closely with wherever they happen to be delivering. It's not necessarily going to be Amita, but we're happy to provide our information. And then we were teaching about trauma-informed care throughout the system before COVID happened, and we were definitely trying to incorporate that as well. So information I can share, I'm happy to do.
And what state are you in? I missed what state, Lita.
Illinois. We're at Amita Health Alexian Brothers in Hoffman Estates and in Elk Grove Village.
Okay, great. I think Meg is going to provide me with all of your email addresses, so I will reach out to you and see if you have resources that might be helpful to share. That would be wonderful. Thank you so much.
And Lita, I can't see the registration list right this second. If you registered using a Gmail account, just private message me your whatever email is the best one to reach you at so that we can loop back.
Okay, sounds good.
Thank you. And so one of the things that Dr. Hall did talk about was, and I'm just looking at the poll, and so I wanted to respond to something that I see here, was she did talk about the online delivery or the standardized education and presentation of education that we make available. So what we do is we work with Dr. Hall. The resources that she has that are patient facing are all integrated into our single platform of clinically reviewed, nationally aligned educational resources. And I apologize, my dog just sat on the electrical cord, so I don't know if I just went black in the background. And so we have all of those resources available in a single standardized platform. What it allows you to do is to be able to actually do education presentation in the hospital. So throughout their pregnancy, we've created a preparing for baby playlist or educational protocols for patients that can be accessed by patients anywhere, 24/7 on any internet-enabled device, and can be accessed by clinicians for at-bedside learning or in-clinic learning, so that it's all getting very consistently delivered to patients and easily accessible to them. We are hearing a lot right now during this time that childbirth educators are seeing great value in this, because where they used to gather in person, now they're trying to give education remotely. This platform allows you to then present that education and make it available for them to seek out as they want to find more information. That value is that it's aligned with your own facility brand. You can add your own resources to it. Everything we provide is clinically reviewed. It's metadata rich. It's in English and Spanish, and always developed at the 5th grade level. And then in addition, it is a great way for you to be able to ensure that patients are going to you as the trusted resource, rather than going out to Dr. Google, where, especially at this time, people will come back with information about, no, I think I have impetigo, or, whatever. And it's like, well, not really. So that is one of the things that we do offer. And what we can do as a follow-up is share a link for you to browse that resource. Again, it is very carefully curated education. We do all the lifting to make sure that it is accurate and up to date. In addition to that delivery online, that education is then available to be integrated into your EHR workflow. So if you are using Epic or Cerner or Meditech, that same education can then also be delivered, tracked, and documented right within your EHR workflow, thereby also making it a very consistent experience. We know that when staff have something that's easy to access and available within the clinical workflow, there's a lot more time for that consistency to take place and for that one-on-one individual learning that drives up both patient and staff satisfaction, that one-on-one connection. So we do make that available through the products that we offer, and we would be happy to send follow-up information to all of you. I do recognize some of the names on presentation today, and that some of you are already using it. You might be using our newborn channel. So it might be news to you that you can also have it digitally available in the site that she's showing, as well as available in your EHR. So we can actually give you the information on that. Any other questions? We're coming up to the top of the hour here, or comments? Okay. We appreciate your time. We appreciate you and everything that you do. And you will get a follow-up. Oh, there is a question. I'm so sorry. Kathy asked, how are CEUs awarded? And I think you talked about PACLAC, Dr. Hall, but if you want to just touch on that. Thank you, Kathy.
Our learning platform is very robust, and it has the capability to award the learner their certificate right on the spot as soon as they complete the course. And then we file the information with PACLAC, which is our certifying agency. So when you log in and make a profile, you have to indicate your job role, like nurse or doctor or midwife, and then you have to specify the type of credit that you're interested in. So if you're a nurse, you're interested in CEUs, and you have to put in your license number. As long as you do those things on your profile, the certificate comes up as soon as you finish a course.
Thank you. Any other questions, Kathy?
And I will say also that, you know, they stay in the system. So I have had a lot of people who completed all the courses and then waited until their license needed to be renewed. And then they, you know, emailed me, I need all of my certificates. I can go in, any of our staff can go in and get all of your certificates for you and email them to you if you want us to. So.
Great. Thank you. Any other questions? Okay. So again, we do appreciate you and thank you for your time. We will have a follow-up email sent to you with links to the program, as well as to this resource that she has on the screen right now, so that you can browse the patient-facing and patient-centric education that's available through the Wellness Network. Thanks again for your time and for joining us.
Thank you, everybody.